Hey, kid. How you boys doing?
The major feature of hepatorenal syndrome is kidney injury that occurs due to the severe chronic liver disease or due to the acute liver failure. The presence of kidney injury be determined by a reduction in glomerular filtration rate and increase in serum creatinine, and important that kidney injury occurs in the absence of substantial alterations in kidney histology, which means that it's not kidney disorder which caused kidney injury. In this case, kidney injury occurs secondary to liver disorder. Hepatorenal syndrome is potentially reversible condition, but once hepatorenal syndrome develops, we immediately know that patient has a very poor prognosis. Nowadays, we have two types of hepatorenal syndrome. The difference is that in type 1, the impairment of kidney function occurs abruptly, and type 2 is characterized by chronic impairment of kidney function. So, in simple words, in type 1 hepatorenal syndrome, acute kidney injury develops. In type 2, chronic kidney injury develops. So, let's explain the pathogenesis of hepatorenal syndrome.
Listen, everybody. Be calm, cooperate, and this will all be over in a minute.
First of all, in order for hepatorenal syndrome to develop, patient should have severe liver injury, as advanced cirrhosis, for example. Recall that advanced cirrhosis develops step by step. Initially, patient has normal liver, then alcohol consumption or insulin resistance cause formation of steatosis. After this, if patient continues to drink alcohol or if insulin resistance persists, steatohepatitis develops.
This is an assault. I have a drinking problem? Fuck you, Peck. You're a Mormon.
Ozzy.
Next to you, we all have a drinking problem. What the fuck is this?
Steatohepatitis is an inflammatory condition, and in response to inflammation, fibroblasts in the liver tissue begin to produce connective tissue, which leads to fibrosis. Over time, fibrosis progresses to cirrhosis, and cirrhosis can be complicated by hepatocellular carcinoma.
You know what I'm saying?
It's an interesting point. Come on, let's get into character.
One of the major features of advanced cirrhosis is portal hypertension, and exactly portal hypertension is the initial step in pathogenesis of hepatorenal syndrome. To explain how portal hypertension develops, we have to recall splanchnic circulation. Initially, left ventricle pushes blood into the aorta. From aorta, blood is going into the splenic artery that supply blood to the spleen, and mesenteric arteries that supply blood to the intestine, where in mesenteric capillaries fluid exchange occurs. After this, blood from the spleen by splenic vein and from intestine by mesenteric veins is delivered to portal vein. Portal vein drains blood into the liver, where in liver capillaries that we call sinusoids, fluid exchange occurs. After fluid exchange in liver capillaries, blood is going into the hepatic vein, and from hepatic vein, blood is drained into the inferior vena cava. But also, we have to know that in this system, we have additional vessels that remain from embryogenesis. Such vessels we call portosystemic collateral blood vessels. Back in time of embryogenesis, these vessels were crucial. They provided flow to esophageal and gastric veins. Also, they provided flow to paraumbilical and superficial epigastric veins that are located on anterior abdominal wall. And also, they provided blood flow to upper anal canal veins. And from these veins, blood is drained into the inferior vena cava. Adult person in normal condition practically do not use portosystemic collateral vessels, because adult person has portal vein pump line that provides flow of huge amount of blood. From inferior vena cava, blood goes into the right atrium and right ventricle of the heart, then blood crosses pulmonary circulation and goes into the left atrium and left ventricle, and from left ventricle, heart again pushes blood into the aorta, so this cycle can be repeated over and over again. From physics, recall that blood flow from the liver sinusoids to inferior vena cava is equal to pressure inside the liver sinusoids minus pressure inside the inferior vena cava divided on resistance between them, and resistance is inversely proportional to the force power of radius. In person with chronic liver injury, progressive deposition of fibrous tissue causes liver cirrhosis, and the problem with deposition of fibrous tissue is that at some point severe fibrosis will compress intrahepatic vessels as liver sinusoids, and it's the moment when so-called veno-occlusive syndrome begin to develop. So, if obstruction in the distal region of the liver sinusoids occurs, the radius of sinusoids decrease. With decrease in radius, resistance increase, and flow through this area decrease. So, the inflow of blood to liver sinusoids remains the same. The outflow of blood decreases due to the thrombosis. This results in accumulation of fluid proximal to the thrombosis. Initially, blood begins to accumulate in liver sinusoids. With the accumulation of fluid in the liver sinusoids, hepatomegaly and ascites develops. With time, the backup of blood due to an obstruction in liver sinusoids causes accumulation of blood inside the portal vein, and accumulation of fluid inside the portal vein causes increase in pressure inside the portal vein, because recall that hydrostatic pressure is equal to weight of fluid divided on area, and weight of fluid is equal to mass on gravity. In turn, mass is equal to fluid density times fluid volume. So, as we see, with increase in fluid volume, the hydrostatic pressure inside the portal vein increase, and increase in portal venous pressure we call portal hypertension. So, portal hypertension develops. And the combination of portal hypertension and the obstruction in liver sinusoids force a larger volume of blood to go into the portosystemic shunts, just to prevent the rupture of the portal vein. The problem here is that the more severe becomes portal hypertension, the higher volume of blood is going into the portosystemic collateral vessels, and the higher the volume of fluid inside the shunts, the more distended they become. Distension of esophageal veins causes formation of esophageal varices. Distension of paraumbilical and superficial epigastric veins causes formation of caput medusa on anterior abdominal wall, and distension of upper anal canal veins causes formation of hemorrhoids. So, to some extent, shunts help us to deliver excessive volume of blood from portal vein to inferior vena cava, but it's a relatively small volume. Fluid continues to accumulate in the portal vein. After portal vein, blood begins to accumulate in the splenic vein, and after in the spleen. Increase in blood volume inside the spleen causes spleen distension, and enlargement of the spleen we call splenomegaly. Also, blood begins to accumulate in the mesenteric veins, and after in mesenteric capillaries. With increase in volume of blood, hydrostatic pressure inside the mesenteric capillaries increase. Increase in hydrostatic pressure inside the mesenteric capillaries causes edema of mesenteric tissue that results in ascites. So, it's the general concept of portal hypertension in a patient with liver cirrhosis.
Pretty smart.
Yeah, I got my moments.
The problem with portal hypertension is that with time, portal hypertension leads to splanchnic vasodilation, which will cause effective arterial hypovolemia, and it's a crucial step in hepatorenal syndrome.
Is that a fact?
No, it's not a fact. It's just what I heard. That's just what I heard.
Who told you?
They?
The entire pathogenesis of hepatorenal syndrome is based on disturbances in the arterial circulation caused by portal hypertension. We call this arterial vasodilation theory. The concept is that portal hypertension in patients with cirrhosis causes vasodilation in splanchnic circulation. The vasodilation occurs due to the production of various vasodilators, as nitric oxide, carbon monoxide, and endogenous cannabinoids. And the major danger is that splanchnic vasodilation causes reduction in effective arterial blood volume. In simple words, splanchnic vasodilation causes relative hypovolemia in general circulation.
What?
So, the concept here is that in response to accumulation of blood in mesenteric blood vessels, endothelial cells begin to produce nitric oxide and endogenous cannabinoids. These two substances cause vasodilation of mesenteric arteries. We call this event splanchnic vasodilation, and the problem is that the larger becomes the radius of mesenteric arteries, the higher becomes the inflow of blood to splanchnic circulation, and thereby the larger volume of blood will be accumulated in mesenteric veins. The problem is that the larger volume of blood will stay in splanchnic circulation, the lesser amount of blood will be available for general circulation, and exactly this state we call relative hypovolemia or effective hypovolemia.
What?
To explain how effective hypovolemia develops, we have to recall the general concept of blood flow in our body. So, heart pushes blood into the aorta, and through aorta, blood is delivered to various organs and tissues in our body. Every organ has its own resistance, which is regulated by the state of the arterioles. 20% of all blood from the aorta is going into the central nervous system and coronary arteries. 25% of blood is going to the kidneys. Also 25% of blood is going into the intestine, and 30% of blood is going to muscle tissue and skin. After this, blood is going to the venous system, which delivers blood back to the heart. After this, blood is going to the pulmonary circulation, and after pulmonary circulation, heart again pushes blood into the aorta, and this cycle repeats over and over again. Also recall that blood flow is equal to pressure difference divided on resistance, and resistance is inversely proportional to the force power of radius. So, in advanced cirrhosis, vasodilation of splanchnic arteries occurs, which causes increase in radius. With increase in radius, resistance decrease, and with decrease in resistance, blood flow increase. So, in this case, cirrhosis causes vasodilation in splanchnic circulation. As a result, blood inflow into the splanchnic circulation increases. So now, the portion of blood which is going to the splanchnic circulation will be 40% instead of normal 25%. The problem is that splanchnic circulation gives away the same 25% of blood, so 15% of blood will stay in the splanchnic veins. As a result, there will be 15% less volume of blood which incomes to the veins, and this means that after splanchnic vasodilation, there will be 15% less volume of blood which comes back to the heart, and this state we call effective arterial hypovolemia, which means that the total volume of blood in the organism remains the same, but the volume of blood which we can use in the general circulation decreases, simply because 15% of blood becomes stuck in the splanchnic circulation.
I think we were supposed to be doing this.
We did.
And instead, we did this.
The next step in pathogenesis is based on organism response to effective arterial hypovolemia. Once effective arterial hypovolemia develops, organism activates vasoconstriction factors to keep a stable perfusion of the vital organs. But the problem is that systemic vasoconstriction also causes vasoconstriction of the kidney arterioles, and renal vasoconstriction is one of the major factors responsible for kidney injury. So, the logic here is that effective arterial hypovolemia is a dangerous state, because we still need arterial blood to supply other important tissues, as brain for example. So, in response to decrease in effective arterial blood volume, our body activates vasoconstriction factors, as renin-angiotensin-aldosterone system and sympathetic nervous system, which should help us to maintain arterial blood pressure within the normal limits. But also, this has detrimental effect on kidney function, because prolonged renal vasoconstriction can cause kidney injury. So let's illustrate this.
I got an idea. This might be a little crazy. Crazy's better than nothing.
Once effective arterial hypovolemia develops, in response to decrease in blood volume, baroreceptors on heart walls becomes immediately activated. And activation of baroreceptors cause activation of sympathetic nervous system and renin-angiotensin-aldosterone system, which causes vasoconstriction. The logic here is that due to the effective arterial hypovolemia, the lesser volume of blood is going into the aorta, which means that the blood supply to organs and systems will decrease. But blood supply to brain and coronary arteries should remain constant, because without adequate blood supply to brain and coronary arteries, organism will die. So, to solve this problem, organism induces systemic vasoconstriction. Basically, to maintain stable blood income to CNS and coronary arteries, we sacrifice blood supply to other organs. First of all, it's muscles and skin. Due to the vasoconstriction, instead of 30%, now only 20% of blood is going to muscles and skin. This permits us to redirect additional 10% of blood to supply CNS and coronary vessels. The state of splanchnic circulation we cannot affect, because in splanchnic circulation, due to the massive production of vasodilatory factors, autoregulation is completely disrupted. So, to find another 5% of blood, organism needs to constrict renal artery, and with vasoconstriction, instead of 25% of blood, now only 20% of blood is going to supply kidneys. And this creates a huge problem, because with decrease in renal blood flow, glomerular filtration rate decreases, which leads to kidney injury.
And?
It's a cold, hard world. Shit happens.
So, vasoconstriction of renal circulation is the hallmark of hepatorenal syndrome. The danger is that with decrease in renal blood flow, the renal cortical perfusion will decrease, which will cause kidney injury. Also interesting that the level of angiotensin II, which is vasoconstriction agent, increases with the severity of cirrhosis and correlates inversely with glomerular filtration rate. Also, patients with high activity of renin-angiotensin-aldosterone system have worse treatment prognosis. And the second vasoconstriction mechanism is activation of sympathetic nervous system with the production of noradrenaline. And we know that the higher the noradrenaline level, the lower is the glomerular filtration rate. So, sympathetic nervous system plays huge part in renal vasoconstriction.
Have I made myself clear, boys?
Yeah, that's perfectly clear, Mickey, yeah. Just give me 1 minute to confer with my colleague. Did you understand a single word of what he just said?
And the last step in pathogenesis of hepatorenal syndrome is kidney injury, which is caused by renal vasoconstriction. So let's illustrate this. Here we see afferent arteriole glomerulus, afferent arterial, and Bowman space. Blood is delivered by cardiac output to afferent arterial. From afferent arterial, blood goes into the glomerulus. The blood flow into the glomerulus is equal to pressure difference divided on resistance in the afferent arterial, and resistance is inversely proportional to the force power of radius. The blood which enters into the glomerulus has its own hydrostatic pressure, and we know that hydrostatic pressure is equal to weight of fluid divided on area. Weight of fluid is equal to mass times gravity constant, and mass is equal to fluid density times fluid volume. So, the higher the fluid volume in the glomerulus, the higher the hydrostatic pressure in the glomerulus. Hydrostatic pressure is important because it's the major driving force that pushes blood into the Bowman capsule in a process called filtration, and fluid that enters into the Bowman space after reabsorption will be excreted into the urine. A portion of fluid which is left in the glomerulus after filtration goes into the afferent arterial and after into the general circulation. The most important process here is filtration, and filtration is determined by several factors. First of all, it's glomerular filtration coefficient. The second factor is difference in hydrostatic pressure in the glomerulus minus hydrostatic pressure in the Bowman space, and the third factor is oncotic pressure difference. The major factor here is hydrostatic pressure in the glomerulus. In case of patient with severe portal hypertension, deposition of fluid in the splanchnic circulation causes volume depletion in the general circulation, which we call effective hypovolemia. With effective hypovolemia, the income of blood into the afferent arterial decreases. Subsequently, the income of blood into the glomerulus decreases. And the lower the fluid volume in the glomerulus, the lower becomes hydrostatic pressure. And because hydrostatic pressure determines filtration, with decrease in hydrostatic pressure, glomerular filtration rate decreases, which leads to decrease in urine production. And this state we call oliguria. In this case, it will be prerenal oliguria. In response to effective hypovolemia, to maintain stable blood supply of CNS and coronary arteries, organism activates renin-angiotensin-aldosterone system and sympathetic nervous system, which leads to vasoconstriction of the renal afferent arterial. With vasoconstriction, the radius of the arterial decreases. With decrease in radius, resistance increases, and with increase in resistance, blood flow decreases. With decrease in blood flow, the lesser volume of blood will income into the glomerulus. With decrease in fluid volume, hydrostatic pressure decreases, and with decrease in hydrostatic pressure in the glomerulus, glomerular filtration rate decreases. So the lesser fluid volume will income to the Bowman space. With decrease in glomerular filtration rate, the level of creatinine in the blood increases, and also the level of urea increases. Increase in both creatinine and urea is a sign of acute kidney injury. And if we have to say the subtype of acute renal injury, it will be prerenal azotemia, due to the hyperperfusion of the renal tissue. So, in urinalysis, this patient will have low fractional excretion of sodium, which is a key diagnostic feature.
Holy shit!
Nowadays, we have two major criteria for hepatorenal syndrome. In both old and new diagnostic criteria, to make a diagnosis of hepatorenal syndrome, patient should have severe liver disease, as cirrhosis with ascites. The second criteria is increase in creatinine, which is a sign of kidney injury. All other criteria exclude different causes of a possible kidney injury. So we have to know that there was no other factors which could cause kidney injury other than cirrhosis, for example. The additional factor which can accelerate the development of hepatorenal syndrome is bacterial translocation, which is by induction of inflammatory response stimulates splanchnic arterial vasodilation. The logic is that decompensated cirrhosis is characterized by persistent chronic inflammation, which can be detected by elevation of C-reactive protein and by increase in white blood cells. In addition to this, cirrhosis causes increase in production of pro-inflammatory cytokines, which leads to systemic inflammation. With systemic inflammation, permeability of intestinal barrier increase, which permits bacteria from the gut to leak into the mesenteric lymph nodes. And bacteria from mesenteric lymph nodes can trigger hepatorenal syndrome by induction of inflammatory state, which leads to production of vasodilator substances as nitric oxide and carbon monoxide. And additional feature which can stimulate development of hepatorenal syndrome is cirrhotic cardiomyopathy, which leads to decrease in cardiac output. And with decrease in cardiac output, the delivery of blood to the aorta decrease, which only aggravates effective arterial hypovolemia. The only therapeutic option in treatment of hepatorenal syndrome are terlipressin and intravenous albumin.
You are my chosen disciples.
Terlipressin is a prodrug of vasopressin, and terlipressin acts on vascular smooth muscles, and by this it provokes vasoconstriction in the splanchnic circulation. Here you can read the entire pathway of terlipressin, but let me illustrate this on image. The concept is that terlipressin induces vasoconstriction in the splanchnic circulation. With vasoconstriction, radius of mesenteric arteries decrease. With decrease in radius, blood flow decrease, and thereby less blood will deeper in the mesenteric veins. So by this we can increase effective blood volume, and increase in effective blood volume prevents hyperperfusion of kidneys. So by this we can prevent kidney injury.
Good. Great.
The second drug is intravenous albumin. Intravenous albumin increases the oncotic pressure within the blood vessels. So let's illustrate this. With infusion of intravenous albumin, we increase the oncotic pressure within the bloodstream. With increase in oncotic pressure, the blood volume within the circulation increase. With increase in blood volume, the stimulation of baroreceptors decrease, which leads to decrease in stimulation of sympathetic nervous system and renin-angiotensin-aldosterone system. As a result, vasoconstriction decrease, and decrease in vasoconstriction in the renal circulation results in increase in renal blood flow, which cause increase in glomerular filtration rate, and by this we can prevent kidney injury.
So that's it then. No one else really knows anything. Okay. What?
But if therapy is not effective and creatinine continues to increase, patient requires dialysis, and depending on dialysis time, patient will require liver transplantation alone or simultaneous transplantation of liver and kidneys.
Well, what did he do that for?
Don't know, sir.
What's wrong with this one? Oh, nothing, Tommy. It's tip-top. It's just I'm not sure about the colour.
What did we learn, Palmer?
I don't know, sir.
I don't fucking know either.